And to chair the meeting, obviously, will be our chair, Dr. Mbolaji Lawal. I will soon hand over to him. And Dr. Imam, the consultant pediatrician at LASUT, is going to be our moderator for today. So without wasting much time, I would like to hand over to Dr. Mbolaji Lawal to say a few words before we proceed. Dr. Mbolaji Lawal, sir, over to you. I'm not sure he's on the call yet because I haven't seen him. Dr. Imam, are you around?
Yes, I am.
Okay, I would like to hand over to you. I'm sure Dr. Mbolaji Lawal will speak at the end of the meeting. So I hand over to you to introduce our presenter, and then she can start her presentation. Thank you.
Thank you, sir. Good afternoon, everyone. You're welcome to today's meeting, the ground round webinar of the Guild of Pediatricians in Private Practice. Today, our presenter is Dr. Olukemi Tongo, a consultant pediatrician neonatologist at the University College Hospital, Ibadan. She's my big sister, my mentor, my teacher. She's an astute clinician. She'll be taking us today. She's also a senior lecturer in the College of Medicine, University of Ibadan. Her topic today is neonatal sepsis, diagnosis and management, getting it right. I have no doubt that it will be a very enlightening session. I would like to ask that we keep all our questions till the end of the meeting. I'll keep a watch on the chat, and yes, we'll have a question and answer session at the end of our talk. Thank you very much.
Thank you, Dr. Imam. Just to apologize again for barging in, Dr. Mbolaji Lawal is on the call now. Welcome, sir. Do you want to say one or two words before we hand over to Dr. Tongo?
Yes, thank you, Dr. Eletu. Just to welcome everyone again, and to say that, and to thank the presenter, Dr. Tongo. I wish everyone a very successful meeting. I thank Dr. Tongo for coming in to give this lecture. So over to you, Dr. Eletu.
Thank you very much, sir. So Dr. Tongo, over to you. The floor is yours.
Good afternoon, distinguished audience. Our very senior colleague on the call, Dr. Mbolaji Lawal. Good afternoon, sir. And I saw my teacher too, Dr. Bukunle. Good afternoon, ma. Every other protocol duly observed. I use this opportunity to thank the Guild of Pediatricians in Private Practice in Lagos for inviting me to take this topic. It's one of the topics I'm very passionate about. And I must say that I really appreciate what this guild is doing in Lagos. And honestly, I wish this will be replicated around the country, because our children, our babies, they really deserve to get the best. Without wasting much time, let me just go straight to my presentation. I'll be talking about neonatal sepsis, diagnosis and management, getting it right. This afternoon, and the objective of today's presentation, because neonatal sepsis is a very broad topic, so I will just try and confine myself to what we can do in the next 40-45 minutes. So the objectives will be to define some terminologies relating to neonatal, to enumerate the etiology of investigations in the diagnosis of neonatal sepsis, and then discuss the treatment of neonatal sepsis, all with a view to highlighting those things we need to focus on, those things we need to global best practices or to stand so that we can get the best outlined. So I'll just go straight to the reminders that sepsis audience, some are pediatricians, some are medical doctors who are not pediatricians, but definitely they see children, they see newborns, and we need to, present in such a way that everybody would be on the same page. So by way of introduction, I would like to remind us that neonatal sepsis remains a major cause of neonatal mortality and morbidity globally, and also causes a lot of adverse long-term neurodevelopmental outcomes. So we cannot overemphasize neonatal sepsis at any gathering or in any situation. And some of the long-term outcomes associated with sepsis include cerebral palsy, hearing loss, visual impairment, and even cognitive delays, which are things that, even when these babies have survived, we do not want the parents to be saddled with. About 2.4 million newborn babies die annually, globally, with almost half occurring in sub-Saharan Africa. And of course, Nigeria contributes a significant that. About 550 to 600,000 annual neonatal deaths are attributed to infections of neonatal sepsis across board. For every 100,000 live births, they have sepsis in the first month of life, in the first 28 days of life. Additionally, neonatal infections account for about 3% of disability adjustment life years lost, which is similar to the burden of HIV and AIDS. And we know how much noise, how much emphasis, how much investment goes into issues of HIV and AIDS. Not much for neonatal sepsis. And it doesn't cost so much more, neither does it cost in terms of human and material resources or financial resources to take care of neonatal sepsis. It's just that attention we need. Neonatal mortality rate in Nigeria, the latest figure from State of the World Children is about 36 deaths per 1,000 live births, which amounts to about 369, approximately 370,000 newborn deaths per year in Nigeria. And infection is one of the top 3 leading causes. Apart from infection being one of the top leading causes, even among the other 2 causes, that is complications of asphyxia as well as premature, plays a role in those causes of neonatal country. We do not have exact figures. However, hospital-based studies have reported very wide variations in incidence of neonatal sepsis. Some report as low as 7, while others report as much as 55 cases of neonatal sepsis per 1,000 live births. These are hospital-based studies. So neonatal sepsis is not child's play at all. And unfortunately, the clinical features of infection in newborns can be very subtle and non-specific.
Dr. Tongo.
Really, when newborn babies are sick, you cannot tell. Infections in newborns can be rapidly fatal. A baby is no more. Compound, not only Nigeria, generally in low and middle income countries, we have places where they have adequate facilities for fertility, neonatal sepsis. So it is a very important topic in newborn care that we cannot do enough justice to. In this part of the world also, we have a lot of unrestricted use of broad spectrum antibiotics, even high end. People just look at babies and say, oh, he's sick, hit it hard. And then we use high end antibiotics. So this prevalent
Hello, ma. Dr. Tongo, you are breaking up.
Use of high-end antibiotics in this mortality and some other complications. So we need to strike that balance, have a scientific basis. Wow. How about now? Am I okay now? Hello?
Yes, we can hear you now.
Can you hear me now?
Yes, we can.
Hello? Okay.
Hello. Okay. Yes, we can, ma.
Okay, let me carry on. I really don't know how far, you
were still on the introduction. You're about to tell us about the limitations with diagnosis and so on.
Okay. So I said limited facilities in low and middle income countries make the diagnosis of neonatal sepsis with certainty quite difficult. That even in advanced countries where they have all the facilities required for diagnosis, it's still a challenge diagnosing neonatal sepsis with certainty, or promptly enough. So for this reason, we really have to be careful with making with neonatal sepsis so that we do not lose these babies unnecessarily. Then I also said that the unrestricted use of broad spectrum, high-end antibiotics prevalent in this part of the world without proper antibiotic guidelines is associated with high fatality from neonatal sepsis. And of course, it leads to the emergence of antimicrobial resistance, which further compounds the situation. And we have limited choices of suitable antibiotics for newborns, particularly in our part of the world. So this is why we just must get it right when we're talking of treating, recognizing and treating neonatal sepsis in our babies. So we need to prevent morbidity, we need to prevent fatality from sepsis in our prevailing circumstance without predisposing these babies or predisposing the system to further antimicrobial resistance. So for that reason, we've got to diagnose, we've got to treat, and we must get these things right. So that is actually the preamble to today's presentation. I just want to say this, that I particularly appreciate the lead that the pediatricians in private practice in Lagos are taking in the area of newborn care, because WHO has recognized that for us to have improved newborn care, they have come up with a set of NAP goals, every newborn action plan goals, to be achieved by 2035. However, by midpoint, which is by 2025, just 2 years away, there are 4 main goals that are emphasized. Number 1 is to eliminate preventable newborn deaths and stillbirth. Of course, among these newborn deaths includes deaths due to infections, and that 90% of mothers should have 4 or more antenatal visits. 90% of births should be attended by trained health personnel, and 80% of mothers should receive routine postnatal care within 2 days of birth. And this is the aspect that I really want to emphasize, that 80% of districts, which is equivalent to local government areas in Nigeria, in all countries, should have at least 1 inpatient newborn care unit, level 2 units, to provide care for small and sick newborns. If we look around us, level 3 facilities, well, we call them level 3 because that's what what our teaching hospitals and tertiary facilities are all about. How many of them do we have in the country? And even level 2, in some states, they probably have 1 or 2 of these level 2 facilities. And we're expected to have in every local government, in 80% of local government areas. So this is where because some of our private facilities even provide care that we can equate to level 3. So, but let's even say for this reason, it is not dealing with newborn issues at this kind of forum. And I must say, I really appreciate them for this. So we appreciate the private practitioners for bridging the gap in this regard. So now talking about some of the definitions with respect to neonatal sepsis. It's essential we understand some of these concepts and terminologies so that in choosing right investigation and management of neonatal sepsis, we would be able to separate issues. We'll be able to categorize these babies appropriately and make right choices of empirical treatment based on our knowledge of prevailing organisms for the various groups or categories of babies. And then it also helps our data presentation and interpretation for improving quality of care. Because without appropriate data, we would not be able to take correct steps to improve quality of care for these newborns. Because indeed, we have a lot of studies that have been carried out regarding neonatal sepsis in our country. However, the way the data are presented, it's really difficult sometimes to use some of them to inform practice. I'll still get to that in the course of the presentation. So sepsis, by definition, is a clinical syndrome. Neonatal sepsis is a clinical syndrome in newborns, which is characterized by non-specific signs and due to invasion by pathogens. It can be due to any class of organism, but bacteria is the most common cause. We may also have viruses and fungi, but bacteria is by far the most common. So this non-specific nature is what makes it peculiar, is what makes it difficult. It's non-specific nature of the symptoms and signs. Then also, I would like to now define, sepsis is categorized into early onset or late onset. Early onset is when symptoms of this sepsis manifest within the first 72 hours of life. And of course, the organisms here are acquired perinatally. So it's important when we are clerking the patient, even if the patient is coming to us on day 5, we need to ask, when was the onset of symptoms? So if the baby had started having the fast breathing or thermal instability since 2 days, since day 2, day 3, that is early onset sepsis, even though it's getting to us after day 2, but after 72 hours. But once we realize that the symptoms started manifesting within the first 72 hours of life, that is early onset sepsis. Of course, there have been various definitions in the past, but by far the most popular and the most acceptable cutoff for early onset is 72 hours. Whereas late onset sepsis is the babies manifest their symptoms after the first 72 hours of life. And the organisms that cause this are acquired from the nursing environment. Either maybe the baby is at home, so maybe a community acquired, or the baby is on admission in the hospital for one thing or the other, and then he picks infection in the hospital setting. So in this regard, we can see that organisms acquired from the mother's genitalia and all of that from organisms acquired in the nursing environment. And then also organisms acquired in the nursing environment after 72 hours of community, from when the baby acquires it in the hospital setting. So it's important, this is in our mindset when we are dealing with these babies, when we are planning our study design, so that we would separate these things and not just lump early onset infection with late onset, with community acquired, with hospital acquired, so that we can understand the epidemiology, we can understand the sensitivity, antibiotic sensitivity pattern, and be able to choose correctly when we are treating the babies. Then another definition I want to talk about is healthcare associated infection, or what we typically would call hospital-acquired infection. In this case, features of infection, they develop after an initial 48 hours of admission. For instance, the baby comes in for some other problem, and then after a symptom-free period of 48 hours, the baby now begins to manifest clinical signs. That we attribute to, we assume the baby acquired it from the hospital setting, or if the baby comes in with infection and we are treating and symptoms resolve, So after an initial symptom-free period of 48 hours, if the baby develops signs of infection again, then we assume that that infection is acquired from the hospital setting. Sometimes after this period, the baby may even have been discharged, he gets home and then develops symptoms of infection. So we assume in that situation that it's due to healthcare associated, it is healthcare associated or hospital acquired infection, what we used to call nosocomial infection. Then there's another terminology people will come across, especially if the baby is referred from primary healthcare setting. It's a WHO terminology that is used in the IMCI package. It's referred to as PSBI, possible serious, or some say possible severe bacterial infection. This terminology describes newborns with clinical syndrome consistent with sepsis. I mean, as we will describe later, but it is used by this lower cadre of healthcare staff so that they will at least recognize that these babies are sick, refer them, or where referral is not possible, there are some antibiotics that are prescribed for them to use and monitor these babies on a daily basis while they are convincing the parents to go for referral. Then we also talk about culture-proven or confirmed sepsis. That's in that situation, the patient has clinical symptoms, and then we obtain bacterial growth in areas that should normally be sterile, like you do blood culture and it's positive, or CSF culture is positive, or urine culture is positive. So that is confirmed sepsis. And studies have reported positive cultures in as many as 12.5 to 50% of blood cultures in hospital-based studies in Nigeria. Of course, these were babies who came in with signs or with suspicion or with risk factors, and they screened them and got positive cultures. So that's how prevalent infection, confirmed infection is in our setting. In Ilorin and Ibadan, for instance, where the studies definitely separated early onset from late onset or hospital-acquired infection, they reported rates of Ilorin reported 7, Ibadan reported 8.8 positive culture cases, early onset sepsis per 1,000 live births. In some other studies, they represented it by percentages, but just for comparison with what obtains in developed countries, what we have in Ibadan and Ilorin is like 10 times what they have in many developed countries. This is just to let us know that infection is a big deal in our setting. And then we also talk of presumed sepsis or clinical sepsis or culture negative sepsis. These are situations in which babies have clinical features consistent with sepsis, with or without laboratory features, but when we take their cultures, they are culture negative. And this is important because there have been several cases or many cases of, even in developed countries, culture negative sepsis, and these babies go on later in life to show complications consistent with positive sepsis. So in that situation, it's also an important category. So we don't just discard them because, oh, they have signs, but culture negative. So we presume they have infection, or we make a diagnosis of clinical sepsis in such situations, and we go ahead and treat such babies. So what is the etiology of neonatal sepsis? What are the causative organisms? Because that's what typically would guide our antibiotic choice of empiric antibiotics, because when we screen, we definitely cannot get a positive culture immediately to guide treatment. So we typically will base our initial treatment on our knowledge of prevailing organisms and the sensitivity in the environment where we practice. So this is why we cannot afford to lump early onset sepsis with late onset. We cannot afford to lump community acquired infection with hospital acquired infection, so that we make the right choices. You know, the emphasis is on right choices. So in many cases of early onset sepsis, which are due to organisms acquired from the mother's genital tract, or even the hands of practitioners around the time of delivery. So that's why we emphasize clean hands, clean surface, clean equipment at the time of delivery, so that they don't pick organisms. So common organisms for early onset include Staph aureus, E. coli, coagulase negative staph, Haemophilus, Listeria. In many studies in Nigeria, group B strep infection is not common. Even in high-income countries with intrapartum antibiotics, incidence of group B strep infection is reducing now. And then for late onset infections, organisms from the nursing environment, whether community or healthcare facility, are the causative organisms, and typically, commonly, Staph aureus, Klebsiella, E. coli, Pseudomonas, Enterobacter, coagulase negative staph have been reported. Coagulase negative staph is particularly important in preterm, very low birth weight babies in many newborn units. So, because sometimes you get culture reports from the laboratory, and then they see coagulase negative staph, and they refuse to do sensitivity. They tell you it's a contaminant. We cannot regard coagulase negative staph a contaminant in a sick preterm newborn. So for that reason, we really have to work with our friends or people in our laboratories that when they see such, they should please do sensitivity and let us have the results. Of course, in Nigeria, the etiology is quite diverse and complex. Complex because it's so difficult to compare studies, because the various ways these results are reported, they vary widely. In situations where people, they just study every baby on their ward, whether early onset, whether late onset, whether the infection is picked on the ward or the child brings infection from home, they just take all babies with sepsis and then we report the organisms. It's difficult to compare studies in that setting because in some you have a lot of Klebsiella and you cannot tell were they picked on the ward, were they from the community, were they from the mothers. So those are some of the challenges we have that makes it difficult to even have a national policy based on the prevailing organisms. So these are areas we need to look at as practitioners, as researchers, so that we can have data that we can work with. So how do we diagnose sepsis? Of course, the clinical features are there. The biggest challenge in the diagnosis of sepsis is the fact that the clinical signs are non-specific and they overlap that of several other conditions, particularly preterm babies. In fact, preterm babies may not even show any clinical signs, but they are sick. So we need to have a high index of suspicion. We need to be circumspect when it comes to these babies and pay attention to the risk factors. Because of this fear, because if you don't treat them on time, they rapidly deteriorate and die or develop complications. So it has led several people to treating practically every sick newborn with antibiotics, whether or not that is what they have. Sometimes the problem is cardiac and then they are being treated with antibiotics. So this unrestricted use of antibiotics is another problem for newborns, and it's known that it results in several other complications like necrotizing enterocolitis, increased risk of picking multi-drug resistant gram-negative organisms, even increasing risk of death in these babies. So for these reasons, we have to strike a balance. We need to be cautious in selecting those who need to be treated. We do not want to subject people to needless antibiotics, particularly these broad-spectrum antibiotics, because they also have opportunistic infections like even fungal infections. It's been well established that more than 72 hours of broad-spectrum empiric antibiotics, particularly the third-generation cephalosporins, is associated with increased risk of acquiring infection with multi-drug resistant gram-negative organisms. So in this situation, we can see that making third-generation cephalosporin a first-line antibiotic is a no-no. But many times when we do not separate early onset organisms from late onset, from hospital acquired, we now get organisms that are sensitive only to third generation cephalosporin. And on that basis, people now recommend third generation cephalosporin as their first line. We only end up creating more and more problems. And these children are so sick and we don't want them to die. So we keep going on and on and on until we reach our limits. And these antibiotics are not, we don't have very wide spectrum of antibiotics that are safe. We need to exercise caution. So in the light of the non-specific signs of sepsis, we must have a high index of suspicion. So when we're talking of early onset sepsis, we must have a knowledge of the maternal risk factors for early onset sepsis, so that those babies are identified promptly and we do the needful so that they don't go on to develop complications or they don't go on to die. So some of these risk factors would include prolonged rupture of membranes, pre-labor rupture of membranes. Typically, I mean, when mothers are pregnant, they should not, their membranes should not rupture before their term. So when we have pre-term, pre-labor rupture of membranes, we should be suspicious because there is a possibility that the mother had chorioamnionitis and that was what led to the rupture of membranes in the first place. Even if it is not prolonged, if it is preterm, pre-labor, we need to be suspicious. When we have unexplained preterm labor or delivery, if a mother is carrying multiple gestation like 3 and she goes into labor at 31, 32 weeks, we can explain that, we can understand that. Or she's carrying 2 and she goes into labor at 34 weeks, 35, we can explain that. But a mother carrying 1 without any problem and then suddenly goes into labor at 28 weeks is unexplained preterm delivery. So our antenna should be high. Our index of suspicion should be high, that what could have led to such preterm labor and delivery, and we should be suspicious in such a situation. And then when the mother has chorioamnionitis, manifesting as peripartum fever, abdominal tenderness, leukocytosis, offensive liquor, there's a high probability that the baby would have sepsis, so we should have high index of suspicion. Maternal UTI, babies with open congenital anomalies, invasive procedures should warrant sepsis screening and monitoring in babies born in such situations for possible early onset infection. Late onset might not be that difficult because they manifest signs, and that's what typically would bring those babies. So what are the clinical signs to look out for? For early onset sepsis, the most common apnea to start with, that is respiratory rate 60 and above, indrawing, grunting, cyanosis, and hypoxia, which will manifest as low oxygen saturation. These are the most common, respiratory signs are the most common sign of infection. Other conditions too may cause the baby to have respiratory distress. So in that situation, any baby with respiratory distress, it's safe to assume infection, not just treat, but then at least we screen to know whether or not the baby has infection. They manifest with thermal instability. And for them, most of it, especially low birth weight and preterm babies, they tend to have lower temperature, hypothermia or low temperature more than fever when they have sepsis. Some have also used the wide core peripheral difference to as a sign of sepsis. That is, you check core temperature and you compare with the baby's core temperature with peripheral temperature. If there is a wide gap, then that is, it should bring about a suspicion of sepsis. But it's a very insensitive marker because preterm babies are unable, because they don't have adipose, so they are unable to generate that wide core peripheral difference in temperature. They may have feed intolerance, refusal of feeds, vomiting, abdominal distension, diarrhea, if they have sepsis, especially in late onset. Mottled skin appearance, or the baby just appears dusky. In fact, that is a very grave sign. Development of jaundice beyond average, reduced activity or lethargy. In fact, reduced activity is the language used for the people at the periphery because they may not appreciate or understand lethargy. But when you see a child that is not spontaneous, the child is just lying there, you touch, the child just barely responds to your touch, that is reduced activity, and we should be suspicious that there may be something wrong. Tachycardia or bradycardia, capillary refill time greater than 2 seconds, which may imply circulatory collapse, which is already a sign of severe illness in the baby, or the child is in shock outright. Hypoxemia, SpO2 less than 90%. The child may bleed, may have petechiae or frank bleeding from orifices or prolonged bleeding from puncture sites. The child, if they have meningitis, they manifest with seizures, bulging or tense anterior fontanelle, metabolic problems like hypoglycemia. They may have apnea. They may have acute kidney injury. It's a very common complication of sepsis. So if we are not monitoring, we would not know. And of course, preterm babies are the most dangerous. They may not show any of these signs, yet they are sick. So once they have these factors, we should go in search of sepsis in these preterm babies. So this is just showing us an overlap of PSBI with other signs of illness in the newborn. So we can see here the, babies with those clinical signs of that will make you say, oh, there's a possible severe or serious bacterial infection. Within there, you have those who would have meningitis, those who will have just sepsis, or those who will have respiratory. You can see there's a lot of overlap. Some other congenital infections, touches infections, some may overlap with these signs. They may have signs. Respiratory disorders, persistent pulmonary hypertension, meconium aspiration syndrome, they may all manifest. Viral infections, urinary tract infections, tetanus, skin infections, congenital heart disease, and asphyxia or any intrapartum related condition. They may all overlap, with signs of infection. So it's difficult to look away and say, oh, it's because of asphyxia, oh, it's congenital heart disease. When we are not sure, we still treat the child as if it is sepsis until we're able to rule out sepsis in the baby. So what workup do we do to rule out sepsis? Now we have seen clinical signs, or we have seen that the baby has these factors for sepsis. While we do not want to wait, at the same time, we do not just want to do needless therapy. So definitely, the moment we suspect sepsis, either because of risk factors or because of clinical signs, we have to screen them and commence empiric antibiotics in some situations. Of course, the gold standard for diagnosis is either our blood culture, and this blood culture must be properly collected in a closed system. These are some of the reasons that may give us unduly high positive culture rates in babies who probably are not sick. So we should not collect our blood culture from open systems. Some will just stick needle and then the blood will be dropping from the hub. And we say we are doing blood culture. That shouldn't be so. Or some will even break the needle. That should not be so. Whatever we get from such systems, we cannot say for sure that it is from the bloodstream of the patient. The sensitivity of blood culture is quite low in newborn babies because they have low bacterial density. They may have as little as less than 4 colony forming units per mil of bacteria. And in that situation, it's difficult to get positive cultures, even though some systems have been developed to improve the yield in them because of these challenges. And then also when newborns have sepsis, it's not like 24/7 they have the bacteremia. The bacteremia may just be intermittent. So if we happen to take our blood culture at a time when the bacteremia is almost not there, we may get negative culture. Yeah, the child is sick. So this is why we say the sensitivity is low. And this is why sometimes the baby has clinical signs, has other investigative positive results of investigations, yet negative blood culture. And we go ahead and treat such babies for sepsis because we do not know why the blood culture is negative. And then sometimes when the mothers have had intrapartum antibiotics, the babies may have a low yield. And also because we cannot afford to take large blood volumes. For instance, the regular Bactec bottles, the one with the blue cap, that is available, or the regular Oxoid adult blood culture bottles require large volumes of blood. I think 3 to 10 mils of blood. We can't afford to take that in our newborn babies, especially the very small ones. Very low birth weight baby, 1 kilo baby, 1.5. You cannot afford to take even 3 mils. Otherwise, you're already planning to transfuse such a child. So, but luckily we have automated systems like the Bactec PITS Plus, even the Oxoid 2 has the pediatric formulation that has been enriched so that even with low color, small amount, low colony forming units of bacteria in the blood, with as little as 1 to 3 mils of blood in the bottle, they can get positive cultures in very short intervals, like 24 to 48 hours. At least they will tell us from the lab that, oh, it has flagged that it is growing something, and then we may now have to wait for the definitive results later. But it's important that we do our cultures, our blood cultures. Molecular methods, PCR methods have been developed, but those are not widely available. Those are able to, yield results in as little as 24 hours, but they are not widely available for use, particularly in these parts of the world. And of course, when available, they cost an arm and a leg. Then cultures of other sites, urine culture, CSF cultures, they are not part of routine early onset screening. Early onset infection hardly ever manifests with meningitis in the babies, but certainly late onset sepsis does. And even in late onset sepsis, some people don't believe in routine lumbar punctures, except maybe blood culture is positive, or the child has neurologic signs or signs referable to the central nervous system, because the yield is so low and it's such an invasive procedure. So definitely CSF culture, urine cultures are not part of routine EOS screening, except there are pointers to it. But for LOS, that is late onset, we should not ignore this. In fact, the urine is a place where bacteria hide. In these newborn babies, when you are screening for LOS, be sure to check urine for cultures and appropriately collected samples, either catheter catch or suprapubic tap. But we should not give the mother bottles to go and collect urine from a newborn baby, or some will go and squeeze from the diaper. That will not give us appropriate results. But the problem with cultures is that even in the best of places, the result does not come in 24, 48 hours. And you have to start your treatment. You cannot wait. So for this reason, we have to make use of several other parameters, clinical signs and other markers, to determine whether there is infection or likelihood of infection or not. But while waiting, we start treatment in these babies. No single marker has been described as having adequate diagnostic accuracy. So that's why it's valuable if we combine multiple parameters. The hematologic parameters we use, for instance, include our full blood count. It's mandatory, though the interpretation is not straightforward, because we have a wide variation in reference values. And when these babies are born, within the 4-6 hours, their white cell count, rises rapidly till about 3 days. I mean, the neutrophil count rises rapidly till about 3 days, even in the normal situation, before it then begins to drop. So how you now interpret that is something you kind of individualize, because it's difficult to tell consistent with infection or not consistent with infection. I know these changes take place throughout the first week of life. And you can almost say that, oh, these features are consistent. Then it's also important to know that there are some conditions that affect white cell count in these newborn babies. For instance, babies born to mothers with hypertension or preeclampsia, they tend to have low white cell counts, and they may not have infection. So if you use leukopenia in their situation, you may be overdiagnosing sepsis. And of course, exposing these babies to undue antibiotics has its own downside. Babies with fever, with asphyxia, with meconium aspiration syndrome, they tend to have low white cell count without infection. So we need to factor this in when interpreting our white cell count results. But generally speaking, when you have leukopenia of less than 5,000, it is predictive, but not very sensitive, because several babies will have infection and not have leukopenia. So if we are waiting only for leukopenia, we would miss several other cases. Same thing with leukocytosis. A baby's predestined normal white cell count may be 15. So by the time that baby is having a white cell count of 8,000, it's already leukopenia for that child. But because we never knew the child, you cannot tell that, oh, this 8,000 is normal or abnormal. Meanwhile, for another child, full-time baby, his own normal, predestined normal may be 6,000. So by the time that kind of child has a total white cell count of 15,000, it's already leukocytosis for that child. But because it's the first one we are taking, we would not be able to tell that that white cell count is abnormal. But in some situations when you have white cell count definitely above 34,000, that is highly suggestive of infection. But again, not sensitive because not all of them have such. Neutropenia is another feature of infection. When we have neutrophil count less than 1,000, it has a high positive predictive value, but again, low sensitivity. Not all babies with definite infection will have neutropenia. Neutrophilia, the same. When neutrophil count is more than 5,000, we can almost say with certainty that that baby has infection, but not every baby with infection would manifest with that. So it's a complex situation. So we have to, put everything on the table, the clinical features, all the signs we are saying, the presence of risk factors, to be able to tell whether we think this baby likely has, probably has infection or not. IT ratio, that is the ratio of immature to total neutrophil count, is another valuable tool. Any figure that is 0.2 and above, that is IT ratio 0.2 and above, definitely tells us there is infection. But lower values do not rule out infection. So it is highly specific, has a positive predictive value, but the negative predictive value is low. If it is low, it doesn't mean the child does not have infection. Then we have other parameters, combining ratios of the components of the white cell count, of the full blood count. The neutrophil leukocyte ratio of 1.24 to 6.76, or platelet lymphocyte ratio of 57.7 to 94.05 may also be diagnostic, but these are tests that are still being evaluated. But since we have the benefit of a full blood count, we might as well look at all these things, add them all up and see whether this baby has a likelihood of infection or not. This is what has led to the generation of sepsis score. In some situations in developed countries, they have the sepsis predictor. You put in all these parameters, add your clinical signs, and see whether there is a high likelihood of infection or not. Then thrombocytopenia less than 100,000 is another feature of infection to look out for. Inflammatory markers also add to our diagnosis of infection. I think we underutilize these markers, even though they are not specific, but they can provide information. In the presence of infective agents, bacterial agents, C-reactive protein is an acute phase reactant. It rises sharply within 6 hours. Though, like I said, it is not specific, but if you do one after, for instance, if you are suspect, if a baby has these factors for infection, maybe mother with chorioamnionitis, with fever, prolonged rupture of membranes, the baby comes out, is not having any clinical sign, and we check full blood count, check the CRP, and we have a value that is high. It may be the stress of delivery, it may be from asphyxia, it may be any other thing that is causing it to be elevated. But when you now repeat after about 24, 48 hours apart, and you have a value that has now normalized, it can help us to decide that, okay, having gotten a normal value in 24, 48 hours, after an initial normal value, 48 hours after, the value is still normal or still low, less than 10, we can safely say the baby does not have infection. So in that sense, we say it has a negative predictive value. So it helps us to decide, oh, we can stop antibiotics here. But when we have a high value, it may be due to infection, may be due to any other thing. In that situation, you may just want to continue your treatment. But if the baby is stable, no clinical signs or whatever initial signs disappear rapidly within 24 hours, and then we repeat after 48 hours and the value has normalized, we can actually safely say, oh, there's probably no infection in this time. Because once the bacterial agents disappear from the baby's system, the CRP drops rapidly too. So that's why we can safely stop antibiotics if after 48 hours it remains normal. Procalcitonin is another acute phase reactant. which also is similar in interpretation to CRP. It is quite specific, but again, other reasons may make procalcitonin to be elevated, but it definitely helps differentiate between bacterial and viral infections. It doesn't rise in viral infections. In fact, in the presence of viral infections, some other inflammatory mediators will suppress procalcitonin. So when it is elevated, its cost is prohibitive, but in places where it's affordable, why not? And if not, same like CRP, doing serial levels are valuable in telling us, oh, infection is no longer present, we can stop antibiotics. And the cutoff here is 8.1 milligram per DL. If the baby has respiratory signs, of course, we do chest radiograph. We may or may not find anything. So having done all this, how do we treat neonatal sepsis? How do we treat babies with neonatal infection? Number one, our main aim is to treat promptly so as to prevent fatality and prevent complications. But at the same time, we don't want to overtreat and create problems. We don't want to overtreat and create monsters of multi-drug resistant organisms, costs of treating, prolonged hospitalization, separation of baby from mother. We do not want all of those. But at the same time, we don't want to lose any baby to infection. So what we do is start empiric antibiotics while awaiting results of our investigations. And we need not delay. Once the baby has risk factors for sepsis and is delivered, we just wait 6 to 12 hours so that things like CRP, full blood count would have taken, they would have started changing. Because if you do it too early and the parameters are all normal, then we cannot really beat our chest and say the baby does not have infection. So we wait 6 to 12 hours, but as soon as we take our samples, we commence treatment in those babies. Broad spectrum, in the sense of broad spectrum antibiotics, have their downsides, but we want to treat with agents that will take care of the likely gram-positives and the likely gram-negatives. So the terminology narrow, broad appears rational. So when we know that, okay, for this early onset sepsis, Staph aureus is likely, E. coli is likely, H. flu is likely, what are those organisms that would likely take care of it? If in my center we have epidemiology results telling us the likely organisms and the sensitivity pattern in early onset sepsis, certainly if the result is telling me it is a third generation cephalosporin, then that will not be a rational choice for these babies. And the reason being that we know when they are born, they do not have flora. So if we knock them hard with broad spectrum antibiotics from day one, particularly cephalosporin is third generation, we do not give these babies a chance of acquiring normal flora, and nature abhors vacuum. So something will definitely colonize them. And what colonizes in that setting would be bugs that are multi-drug resistant. So once a baby gets colonized by extended spectrum beta-lactamase, carbapenem resistant drugs, in a matter of days, 5 days, 6 days, the child will come down with a hospital-acquired infection or healthcare-associated infection due to these organisms that are not sensitive. And then the cycle goes on and on and on. So that's why we must get it right with the very first choice, especially when we're dealing with early onset infection, when the child may just be risk factors, may not even have the infections to start with. So it is difficult in our setting because of the kind of results we have due to the way we have reported our settings, our studies. So actually, there's no harm in maybe going back to review, because it costs so much actually to plan these studies, pay for cultures, pay for other ancillary investigations. But we may go back and do a secondary analysis of these our results. See if we can separate early onset, people with risk factors only, from late onset, from community, from hospital acquired, so that we can know what is actually proper to treat these babies as first line. WHO recommends beta-lactam antibiotics, that is our penicillins, ampicillin, and genticin, aminoglycoside, as first line, and third generation cephalosporin only as second line if this first line fails. Indeed, we are beginning to get a lot of resistance to this beta-lactam antibiotics because of the abuse that we have around. But that is still the recommendation of WHO. Third generation just for emphasis sake, third generation cephalosporins as first line is not justifiable in our babies, and it is a risky choice in any situation, because in no time you will just find that your system, your ward or your unit is full of babies with multi-drug resistant organisms causing infection in them, and there is nowhere to go to once you start with third generation cephalosporin. So we need, the other important point I'd like to make is that treatment of neonatal sepsis is with parenteral antibiotics. There is no room for oral antibiotics. Though in the setting of primary care level, WHO in the IMCI model or IMCI plan, management plan, recommends where referral is not possible and the baby has those clinical signs and they think there is possible serious bacterial infection and referral is not possible, they've done everything, they recommend oral antibiotics in them. But for those of us on this platform who practice in secondary, tertiary facilities, there is no room for oral antibiotics in the treatment of neonatal sepsis because of erratic absorption. So how do we treat? Who requires to be treated? Start. For symptomatic newborns, a baby comes, it has clinical signs, we quickly take our samples and commence our antibiotics, empiric antibiotics immediately based on knowledge of prevailing organisms and their sensitivity. But for asymptomatic preterms, we said preterm babies may have sepsis and not manifest with clinical signs. So when you have preterm babies, less than 34 weeks and below, with risk factors for sepsis, please screen and commence antibiotics in them. In that situation, that is prophylactic or empiric antibiotics. Then the third category is asymptomatic term newborns with risk factors only. A term newborn, maybe the mother has had prolonged rupture of membranes more than 18 hours, but the child is otherwise well, no clinical signs, or perchance in the labor ward, it has some tachypnea, which disappears rapidly within 6 to 12 hours. That kind of baby, all we need to do is to screen. You know that when a newborn has, when a term newborn has, when a term newborn has sepsis, they would manifest with early onset sepsis, they will manifest within 85% of them will manifest within 24 hours, while the rest will manifest within the next 72 hours. So you watch them like a hawk for those clinical signs, you do your screening, and if after 48 to 72 hours, the term baby does not develop signs, the test results come and they are not consistent with infection, then the baby is free to go home. You don't have to treat such a baby. But for those ones that we start antibiotics, either because they have some clinical signs or the risk factors and they are preterm and all, and we start our empiric antibiotics, by 48 to 72 hours, we need to decide whether or not to continue. Continuing empiric antibiotics beyond 72 hours increases risk of late onset sepsis, necrotizing enterocolitis, and death. These are proven. So that's why we must have results. At least if we don't have the positive culture, depending on whatever our lab is, the situation in our laboratory, if you don't have blood culture results, at least the full blood count results we should have, the CRP results we should have, clinical signs we should have, and be able to say this baby has infection or does not have infection, because the longer duration of empiric antibiotics will put them in trouble. And then our serial CRP, maybe when you do 6 to 12 hours or procalcitonin, and we repeat again in 48 hours, they should guide us. We should be able to say, oh, actually at that initial stage it was 15, CRP for instance, and then now it is 0.3 or it is 2 or it is 5. Then we can say this baby does not have infection and stop empiric antibiotics and continue to monitor the baby's clinical parameters. So this approach would help us to reduce undue antibiotic pressure as well as its deleterious effect without necessarily increasing risk of infection or readmission. And these are things that have been, that reports, studies have shown. Babies who were properly screened, started on antibiotics, 48 to 72 hours will have negative results, even though the blood culture has not come, but maybe the black tech is not flagging, the gas and all that are not showing that, oh, there is bacteria in this system. And the baby is fine, is well, we quickly stop antibiotics 48 to 72 hours. Studies have not shown them to have increased risk of infection later. Rather, it is those ones you just continue endlessly out of, oh, I am afraid, I don't want this baby to have sepsis, yet you have shown that there's no sepsis. Those are the ones that will likely break down later with infection. And then in some centers, when babies are born, they just routinely give them antibiotics to go home, Ampiclox drops. These are some of the things we must stop. There is no place for routine antibiotic prescription like tonic for babies at birth. So when our cultures come and we have positive cultures, we treat these babies for 7 to 10 days. 7 days actually in many instances have been shown to be adequate, particularly when you can do your CRP and it shows you that it has. So because within 6 to 12 hours of the bacteria being cleared, the CRP normalizes. Of course, the higher the CRP, you have some babies with CRP as high as 100, 150, 170. Of course, the higher the CRP, it predicts severity of infection. But once the antibiotics have cleared the bacteria, the CRP drops fast. So if it is not necessary to go beyond 7 days, please don't go beyond 7 days. In some situations, maybe the clinical signs do not resolve fast, then we may have to go as long as 10 days. But if we have treated the baby for 7 days or even 5 days and clinical signs are not resolving, then it's either it is not sepsis or the antibiotic is not touching the organism. So we have to review such patients. So having talked about antibiotics and well, I have not mentioned specifically what antibiotics, but WHO recommends ampicillin or penicillin with gentamicin. In my own center of practice, based on our experience and culture results, our first line still remains the same. We use unacin, which is a protected ampicillin, I'll put it that way, and amikacin. When we did not get unacin to buy, when it became scarce in the country, we were using Ampiclox and amikacin, and we were getting similar results. So, it is left for centers to choose the antibiotics based on the prevailing organisms and the sensitivity pattern. But it is certainly not advisable to have third generation cephalosporin as first line. New antibiotics are being developed, but all these are still in the pipeline. There is not enough evidence yet to say, oh, we should use these newer antibiotics. And definitely not, because these days you find carbapenem, colistin, all manner of antibiotics, in our different centers, and we're just complicating issues for these babies. So apart from the antibiotic therapy, the supportive care is just as important as the specific therapy. Sometimes your antibiotics will be clearing the bacteria, but because of the inflammatory mediators released, the child is in shock. The child is having severe respiratory distress. We have to provide supportive therapy as needed, because most of the time it is lack of the supportive therapy that kills the baby, even when you have cleared the bacteria. So we need to monitor respiration and support as necessary. Support as necessary means give oxygen, escalate to CPAP, mechanical ventilation as required by the baby, based on presence of hypoxia, based on abnormal blood gas, based on presence of increased work of breathing. We monitor circulation. If necessary, we give fluids, we give inotropes as necessary, because this is something that many people often neglect. When you see mottled skin, it's telling us that circulation is poor. And we have invasive methods of monitoring circulation to know IVC is open, is not open. Even our capillary refill time will tell us whether the child circulation is good or not. So we may have to give fluids as important as necessary and inotropes to follow, but not inotropes before fluid resuscitation. Nutrition is very important because their metabolic rate increases when they are sick. And of course, the best thing for them is breast milk. If the baby is unable to suck, if the baby is able to suck, let the baby suck by mouth. If the baby is unable to suck, we express breast milk and feed by alternate routes, especially for our low birth weight babies. We feed them by tube, or we feed them by cup or by spoon. But if milk feeds are not feasible, for instance, the baby has GI complications, abdominal distension, gastric dilatation, and all that, you don't want to feed during such periods, then you may have to resort to parenteral nutrition. But certainly they need more than water. They need more than dextrose and electrolytes. So we need to consider this when treating our babies with sepsis. I have seen in some situations, people will just fast babies endlessly. They say the baby has sepsis. There is no such thing. If the baby has GI symptoms, you may want to rest the gut for a day or two. But if the baby does not have GI symptoms, please go ahead and feed these babies. Of course, we need to monitor the renal function because AKI is also a common complication of sepsis, particularly in the very low birth rate and very preterm babies. So we monitor our fluid input and output. And we need to note that in this situation, some of these babies have non-oliguric renal failure. So it's not enough to just do input and output. We have to check their electrolytes, urea, and creatinine as well. You do urinalysis, do urine specific gravity, so that we know what exactly the patient has. Monitor their random plasma glucose. They may have hyper or hypoglycemia when they have sepsis. We need to ensure adequate and not excessive glucose infusion rates. When these babies are on intravenous fluids, we must monitor their glucose infusion rate. If it is excessive and they develop hyperglycemia, the hyperglycemia would even kill faster than the sepsis we are treating. And of course, our developmentally supportive care, we just cannot overemphasize that, because while waiting for the bacteria to clear, we need to protect the brain, we need to support the motion of the baby. So positioning, KMC, and all of those are things we use to provide this developmentally supportive care. If the baby has jaundice, we treat as necessary. But we need to know also that the blood-brain barrier becomes compromised in the presence of sepsis. So you may want to do an exchange blood transfusion earlier than the cutoff value you would, because sepsis puts them at high risk of bilirubin encephalopathy in the face of infection when they have jaundice. So we also cannot overemphasize the need for infection prevention and control, as well as judicious use of antibiotics. That is key in the treatment of sepsis. The WHO emphasizes nurturing care for small and sick newborns so as to achieve early childhood development. And this is quite essential, and it's achievable within whatever system we practice. It is achievable. And the evidence-based interventions to achieve this include family-centered care, which is about zero separation, which is about allowing family members to have access to their babies, which is about making the family members feel good, allowing them to touch their babies, just show them what to do. They wash their hands, they participate in the care. Of course, minimal handling, but then they touch their babies, talk to their babies, sing to their babies. The baby smells the mother. The baby is in kangaroo position. If the mother is not, some now say kangaroo care. Well, it's still kangaroo mother care, whether it is the mother providing it or the auntie or the father or the grandmother. And, you know, immediate kangaroo care is the thing, is the way to go now. But if the baby comes, you know, much later and is sick, provide kangaroo mother care. It helps them, helps the mother, helps the baby. And of course, baby-friendly initiative that supports the mother for breast milk feeding is so crucial in the supportive care of babies with sepsis. And then the fourth thing is safety and security through infection prevention and control. So we just must have that habit of hand washing. We see many people looking after babies. They wear long nails, they wear rings, they wear long sleeve shirts, they wear bracelets in the newborn ward. They say they wash hand and they are touching these babies. They wear long hair, the hair falls over the baby. Somebody would have washed hands and touched the hair and go back and touch the baby. All these things go a long way in messing us up. So we need to pay attention to infection prevention and control, safe disposal of waste, but above all, our hand hygiene and asepsis in all we do with these babies. Judicious use of antibiotics, we cannot overemphasize. And judicious means using the right choice, not too broad. That's why we have the concept of narrow broad, based on our knowledge of prevailing organisms. We use it appropriate dose, appropriate route, and for the most reasonable length of time. If the baby requires 72 hours, stop at 72 hours. If the baby is actually being treated because it has clinical signs, because it has positive cultures or positive investigation results, then use for the 7 days you want to use. And of course, again, safe oxygen use. Oxygen itself would increase inflammation if it is used unnecessarily. So we use our saturation, our severity grading for respiratory distress to guide our oxygen use in these babies. Oxygen is not water, is not innocuous, so we should only use when it is necessary and as much as necessary. So that takes me to the issue of many of us have oxygen, we don't have compressed air. So we need to emphasize the need to have compressed air so that we can titrate our FiO2. We shouldn't just be loading them with 100% oxygen all the time. Just give as little oxygen as the baby requires to maintain saturation between 90 and 94 or 95% without increased work of breathing. So I think at this point, I would like to stop and take questions. Thank you for your attention thus far.
Thank you. Thank you very much, Dr. Tongo, for this enlightening session. As I said earlier, that we were in for an enlightening class, and I believe that Dr. Tongo has done justice to the topic. We'll now take questions. In the chat group, we have 3 questions so far. Dr. Ogunrinde says, do you think that the lack of facilities to detect other causes of infection, apart from aerobic organisms, could contribute to the high percentage of bacterial sepsis? Dr. Okafor wants to know if congenital malaria can be a cause of neonatal sepsis. And then Dr. Ogunrinde has another comment. I think it is beneficial to draw a line between neonatal sepsis and neonatal infection. I think this will better focus on the distinct management approach of neonatal sepsis. I feel uncomfortable when cardiorespiratory management of neonatal sepsis is downplayed. Okay, yes. So I'll let Dr. Tongoma, if you would answer these questions. There are several other people saying what a wonderful presentation it has been. And some people are asking for a recording of the slides. I think the association will take care of that.
Thank you very much.
Oh, sorry. If allowing family members to handle babies is applicable to babies in the newborn units. Yes. So over to you, Ma.
Thank you very much. Let me start from the last one. Certainly, you know, we talk about family-centered care, and that implies involving the family, especially the mother, father, maybe siblings, in the management of their baby. It's bad enough for them that the emotional component of having their child on admission separated from family members. So the emphasis now is allow them in, but of course you draw your line, you give your rules. They must maintain asepsis. They are better off handling their babies than us healthcare workers. If they are going to bring bugs to the baby, it would even be their family or community organisms that will probably be easier to treat than what we healthcare workers carry from patient to patient. So if they are handling their babies, there will be less handling from healthcare staff, particularly in the face of a shortage of hands. It's just that we have to show them how, maintain asepsis, hand hygiene when they are touching, particularly when you even want them to do KMC. You want the aunt or father or whoever is available, once they've had their bath, to do KMC for these babies. I mean, evidence shows that these things work. So we want family members in the newborn unit. Well, of course, no matter what it is, we should focus on having family members partake in the care. It helps them to feel good. It helps them to experience, have a good experience of care on behalf of their baby, and the baby too experiences good care. And it's been shown that the babies do better when we allow this to happen. So the other comment, thank you, Professor Gunide, is about the issue of neonatal sepsis, neonatal infection. For newborn babies, it's a difficult distinction. And actually, it's more like academic exercise because bacteria has no business in the body of a newborn baby. So if we say neonatal infection is a separate thing and then sepsis is a separate, sepsis is actually the clinical manifestation or the clinical syndrome that we see when they have infection and they are sick. But we know some babies have infection and they don't show up sick until it's late, particularly preterm babies. You may just come one evening and say, oh, the temperature has been normal because you are maintaining it in an incubator or with KMC. And the child has not shown any sign. And then suddenly he has apnea. And before you know it, he's in circulatory collapse and he's dying. So for those reasons, there is hardly any distinction between a baby has infection, a baby has sepsis. So once a baby has risk factors, once a baby has clinical signs and we screen and we find bacteria, we label it confirmed sepsis or confirmed infection, and we treat appropriately. If the baby has risk factors and is preterm, we screen and we treat. When our results come out and they are not consistent with infection and culture is not positive, we stop within 48 to 72 hours of treatment because we don't want prolonged antibiotics to cause more problems in our babies. And then also, indeed, the fact that we don't have good lab support, particularly those of us in government facilities, even when the laboratory facilities are there, because of out-of-pocket expenditure. In my own hospital, if you don't pay, you don't get the test done. Even when they have to go and do it in outside facilities, there are some sophisticated laboratories outside now, but their cost is killing. The parents cannot afford it. And then the baby comes now, he has features or risk factors you want to screen, and the father has to first go and raise money and come back after 2 days, by which time you have already started treating. So when they come after 2 days and you take your samples and the result is now negative, one is really not sure. Is it the treatment that made the baby negative or because the baby was negative ab initio? So in that situation, you want to repeat things like your CRP or procalcitonin, so that if you have a repeat value and it's repeatedly negative, then that may make us stop. But in a situation where they can't even afford and you can't repeat immediately, it goes on and on and on, now further predisposing to more infection. So we cannot, we cannot underrate the effect of this situation, not having adequate lab support, in the frustration we experience with respect to diagnosing sepsis, managing sepsis, controlling antimicrobial resistance in our setup. But something tells me that people in private practice might be better off and they might actually be able to help us, because people who go to them, I imagine, I don't know, they probably have the money to pay, so they can actually do the investigations as at when due. They give the treatment because maybe patients don't pay immediately for services. So they may have better statistics or data to guide or inform practice. If that hasn't been the case before, now let's begin to look at it. Maybe that will help us to at least know what is prevalent in our environment if we conduct these studies, the designs properly, and we come up with the results. Thank you. I hope I've answered the few questions.
There were two additional questions. One about micro ESR. Is it still considered relevant in irrelevant investigation for neonatal sepsis? And somebody wanted a cutoff value for procalcitonin and for CRP. Okay, thank you very much. Micro ESR is actually one of those ancillary investigations that is not
in itself discriminatory enough, but at least when it is abnormal, it adds something. So when you do micro ESR in a baby who has risk factors, and there may be some parameters in the full blood count are abnormal, when you add all of that together, it helps us to at least strengthen that suspicion whether this baby likely has sepsis or not. And what's the cutoff for micro ESR? It's is the baby's age in days plus 3 is the cutoff. So that's the other thing, is there is not one single cutoff. If the baby is 2 days old, the micro ESR 5 and above is suggestive. If the baby is 3 days old, 6 and above is suggestive. So those are the things to consider. The cutoff for procalcitonin is 8.1 milligram per DL. Cutoff for CRP is 10 micrograms per DL. So 10 milligram per DL, milligram per DL. So when a baby has above 10, it's suggestive of CRP, has above 8.1, is suggestive for procalcitonin. But values below that tell us that this baby does not likely have infection, especially when we repeat and it is still lower than those cutoffs.
Thank you very much, Ma. It seems, the longer we stay, questions are coming in. Yeah, so final, no more questions. This one, this lady is asking, please, Matt, stopping antibiotics between 48 to 72 hours, this is applicable to extreme preterm babies? And then there's a longer comment from Dr. Anna.
Thank you very much. If an extreme preterm baby, maybe a baby born to a mother with, she had prolonged rupture of membranes. The baby comes out, it has respiratory distress, and you take your samples and you screen, you start your respiratory support. In fact, if the baby has bad distress and you think it merits surfactant and you have it and you give, and the distress resolves, your full blood count is not consistent with sepsis, your CRP, maybe day 1 is 0.2 or is even 5, and then you repeat after 48 to 72 hours, it is still less than 10, maybe 5 still, there is no reason to continue antibiotics in such a baby, because they are actually the ones that are at increased risk of having late onset infection with hospital bugs, increased risk of having necrotizing enterocolitis. So in them, you stop 48 to 72 hours if your parameters are not indicative of infection and the baby is clinically stable, is well. The only time it's difficult is when, for instance, the baby has respiratory distress from respiratory distress syndrome. You have given your surfactant or you're unable to give surfactant because they cannot afford it, and the baby is still dyspneic. We know that because the clinical signs are still present, in that situation, you have to continue to treat the child because the RDS itself will predispose to chest infection because macrophages and all those will be destroyed. So in that situation, you continue to treat and continue to monitor until, you get definitive results. But there is no room for us to just keep giving them because they are small and then we keep giving them antibiotics as if it's part of their daily need. In some situations, I've seen people you say, oh, today is the 14th day. You wonder, what are we treating? Nothing is suggestive. Just the fact that the baby is small. That is not enough reason to keep giving. It's even in those ones that we really have to be cautious. It's not that ab initio you cannot look away. You start your empiric treatment. Screen. Look at clinical signs. If nothing is positive, please stop 48 to 72 hours. Even if the person now picks a bug later in the course of care, the probability that they will pick bugs that are sensitive to simple antibiotics is higher than the possibility of picking multi-drug resistant bugs. If a baby is on broad spectrum antibiotics and he picks a bug, that child will likely have multi-drug resistant infection. That child is at increased risk of fatality. That child is at increased risk of adverse outcomes in terms of necrotizing enterocolitis, retinopathy, or prematurity. So we need to balance things. Thank you very much.
Thank you very much, Dr. Tongo. I know if we give more time, we won't end this meeting. We see that some people are already leaving. I want to say a big thank you for this presentation. No doubt we've learned quite a lot, even though we thought we know so much about management of neonatal sepsis, but you've actually given us more insight as to what we should do. We had more than 100 people on the call. At the point, we had to go to the Zoom link for some other people to join. And so I want to say a big thank you. Just before we round up, to let everybody know that we'll send the recordings later in the day or early tomorrow morning for those who may still want to watch the presentation over and over again. Dr. Mobolaji Lawal, do you have any last words, sir, before we close? Dr. Mobolaji Lawal, are you on the call?
Yeah. Am I audible now?
Yes, sir, you are.
Okay, yes. Just to thank you, Dr. Letu, and to join you in thanking Dr. Tongo for sharing her thoughts with us on this very important topic and for doing so clearly and so eloquently. And also our moderator, Dr. Imam. I thank Dr. Tongo further for her acknowledging the effort of the private sector in Lagos in the care of newborn babies and in offering level 2 neonatal intensive care unit care, and on some occasions level 3. I'm sure there are a few other hospitals outside Lagos which are offering this kind of care, and it is in pursuit of improving the skills of the people giving this care in private sector that this group was formed. I need to mention that the group is a national body. Although it was formed in Lagos, we have members from all over the country. And the topics which incidentally have become popular by way of attendance are carefully chosen to emphasize clinical topics, and topics that are likely to impact on the care that is being given in private practice, private pediatric practice. So it's a national body, and there are members in the group all over the country, although majority are in Lagos and in the big cities. So thank you again, Dr. Tongo. We really appreciate your being here. And to everyone who has joined today, I'm sure Dr. Letu is going to let us have the presentation recording later on. So thank you very much, everyone. Over to you, Dr. Letu.
Thank you very much, sir. So Dr. Tongo, once again, I say a very big thank you for creating the time to present, to make this presentation. And like I always say, before I end, I will come knocking on your door again at some point. So bear with me if I do so. Our next meeting will be on the 30th of March, 2023. And incidentally, that will be during the period of the population census. I'm not so sure many people are aware there's going to be a national census next month. I think we're all preoccupied with the elections, but the elections will be over by then. So we expect that we'll have the same number of participants at the next presentation. So a big thank you once again, and good night, everyone. Bye for now.
Thank you.
Bye-bye.
Thank you very much. Goodbye.
Thank you.
Bye, everyone. Yeah.